Welcome, future nurses. Grab your notebooks, silence your phones, and get ready because today we are doing a highly structured, comprehensive review of chapters 23 and 18. I am so excited to guide you through this explainer. We're going to break down these really complex clinical concepts into a dynamic format to help you absolutely crush your upcoming NSG 331 exam with Dr. Kuykendall. Okay, let's dive right in.
But before we get into the clinical heavy lifting, I want you to just take a second to reflect on this quote. We have the power to make ourselves. Honestly, your success on this quiz and your confidence when you're out there on the floor as a nurse, it depends entirely on the preparation you're choosing to do right now. You're putting in the work by being here, and that is exactly how you build a rock-solid foundation.
So here is our roadmap for today. We'll be hitting strokes and TIA differences, a cerebrovascular case study breakdown, neurodegenerative disorders and communication, pain in older adults, and finally, pain assessment and interventions.
All right, let's kick things off with Section 1, Strokes and TIA Differences. Now, exams literally love testing your ability to tell similar-sounding cerebrovascular conditions apart, so you really want to pay attention here. First up, you have to be able to contrast a transient ischemic attack, a TIA, with a full cerebrovascular accident, or stroke. So both of these involve interruptions in blood supply to the brain, and they mostly happen in folks older than 65. But here's the critical distinction your professor highlighted. We usually think of TIA deficits as temporary, right? Actually, scratch that. If those deficits stick around, they can take up to a full year to completely resolve. Definitely keep that timeline in your back pocket for the quiz.
Next, we need to understand the breakdown of stroke types. Ischemic events are driven by four main culprits: arterial disease, cardioembolisms, which are often caused by arrhythmias, hematologic or coagulation disorders, and systemic hypoperfusion. Contrast that with hemorrhagic events. While hemorrhagic strokes are less frequent, they are significantly more life-threatening.
Moving right along to Section 2, Cerebrovascular Case Study Breakdown.
Let's take these textbook definitions and anchor them in reality with a case study. The case of Nancy is the perfect blueprint for the kind of clinical application question you're going to see. So here's the scenario. Nancy is 79. She comes into the ER with left facial droop, left-sided hemiparesis, expressive aphasia, and mild dysphagia. This image brilliantly illustrates the diagnostic process. What we're looking at is a non-contract CT scan that confirms a thrombotic CVA in her right hemisphere. And remember that golden rule: right brain damage often shows up as left-sided physical deficits.
So stop for a second. Let's do a quick knowledge check based on Nancy's chart. Think about her past medical history: hypertension, hyperlipidemia, and paroxysmal atrial fibrillation. Which of those likely caused this event? Think back to those causes of ischemic strokes we just talked about.
If you guessed her history of atrial fibrillation, which causes those cardioembolisms, and her hypertension, you hit the nail on the head. Now, as her nurse, you have to know the testable emergency actions for this. You're going to administer the Clotbuster TPA per protocol, do your neuro checks and vitals every single hour, and this is absolutely crucial: keep her NPO, nothing by mouth, until she gets a swallowing evaluation. Because she has dysphagia, preventing aspiration is priority number 1.
Let's jump into Section 3, Neurodegenerative Disorders and Communication.
Okay, shifting gears from acute events to slow-onset neurodegenerative disorders, let's look at Parkinson's disease, which is a progressive movement disorder slightly more common in men. You need to memorize these 4 major clinical signs: resting tremor, muscular rigidity, bradykinesia, and an asymmetric onset. But here is a sneaky detail that is prime trick question material. That resting tremor, it's actually not present during sleep, but it spikes big time with stress and anxiety. Lock that fact in for test day.
Now, as disorders progress, communication changes like aphasia become really prominent. This right here is a massive target for vocabulary matching on your quiz. You have to know the difference between fluent and non-fluent aphasia. Fluent aphasia comes from damage to the Wernicke area. The person speaks easily, but the content makes absolutely zero sense. Non-fluent aphasia, on the other hand, means damage to the Broca's area. They speak incredibly slowly and struggle to get even minimal words out. So just remember, Wernicke equals fluent nonsense. Broca equals slow, non-fluent struggle.
Time for another knowledge check. Let's say you're caring for a patient with dysarthria, meaning they have physical difficulty articulating their words. What is the very best nursing intervention to help them communicate?
The evidence-based answer here is to conduct your conversations in a quiet, private place. It just makes sense, right? You want to eliminate environmental distractions and bring their stress levels way down. You'll also want to collaborate closely with a speech and language pathologist and look into alternative electronic communication devices to support them.
All right, moving into Section 4, pain in older adults.
Applying our neuro-knowledge to Chapter 18, we really have to bust some dangerous clinical myths. These are the misconceptions that constantly lead to older adults being undertreated for pain. Listen closely. It is a myth that older patients experience less pain. It's a myth that confused elders don't feel it, or that they're just complaining for attention. And clinically, you can never ever assume that just because an older patient's vital signs are normal, they aren't in severe pain. Vital signs do not always spike with chronic pain.
Also keep in mind that for older adults, acute pain is super often layered right on top of pre-existing chronic pain. And what's the biggest culprit? Arthritis. It remains the single most common pain-associated disorder for this age group. So whenever you assess an elder patient, you have to assume pain is a complex, subjective experience that requires you to actively investigate.
And that brings us to our final section. Section 5, Pain Assessment and Interventions.
Let's talk about OLD CART. This acronym is basically your best friend. It's the fundamental mental scaffolding for any pain assessment. Onset, location, duration, characteristics, aggravating factors, relieving factors, timing, and severity. If you just systematically walk through those letters, you are going to get a wonderfully comprehensive, subjective pain picture from any patient who can speak with you.
But what happens when they can't tell you? Think about this quiz simulation. How in the world do you assess pain in someone who has advanced dementia or severe aphasia and simply cannot use words to describe their pain using OLD CART?
You use specialized observation-based tools. You absolutely need to recognize both the PAIN-AD scale, that's pain assessment in advanced dementia, and the PAC-SLAC checklist. These are your go-to tools for seniors with limited communication. They rely entirely on you picking up on behavioral cues. We're talking negative vocalizations, facial grimacing, tense body language, or changes in how easily they can be consoled.
So let's wrap this up with interventions. When it comes to meds, remember that acetaminophen is considered the gold standard for treating something like mild back pain in an older adult. But beyond that, you need to know your CAM therapies, complementary and alternative medicine. Think TENS units, acupuncture, therapeutic touch, heat and cold, guided imagery. These non-pharmacologic interventions are game changers for promoting comfort without risking the nasty side effects of polypharmacy.
Okay, you've done your assessment, you've implemented your interventions. How do you know if it actually worked? Use the PAIN acronym. P, pick up on their mood. A, assess verbal cues. I, inspect those facial expressions, looking for that grimace to fade. And N, notice their body language. Has that rigid, tense posture finally relaxed?
Well, future nurses, you've got the structured review you need. But beyond just acing this quiz, I want you to ask yourself, as our aging population keeps growing, how are you going to use these skills to totally revolutionize pain management and advocate for patients who can't speak for themselves? Keep studying, stay focused, and you are going to do amazing. See you next time.